In 1887, Dr. Jean-Martin Charcot observed that traumatic experiences could lead to attacks that might happen years later. Living with PTSD and past trauma, tonight, On Call with the Prairie Doc, celebrating our 20th season. Hello, I'm Dr. Jill Kruse, your host this evening. Tonight's On Call with the Prairie Doc program is part of the celebration of 20 seasons of truthful, tested, and timely medical information. We continue this tradition this evening as we discuss PTSD and past trauma. Joining us to address that topic are Drs. Matthew Stanley and Dr. Veronica Radigan of Avera Medical Group University Psychiatry Associates, Sioux Falls, South Dakota. Welcome. Thank you so much for both of you ferrying a very blustery and winter-like April day to come up here in studio with us.
Yeah, not quite the spring day we hope to have, but we're very happy to be here, Jill. Thank you.
Yes, so tell me a little bit about yourselves here and introduce yourself to our audience. Matt, you're no stranger to the show. Our guests know you well.
Yeah, so I have been on a few shows, and Jill and I have been through Physicians Academy at Avera together, so we know each other pretty well also. So I'm a psychiatrist in Sioux Falls, primarily practice at the Avera Behavioral Health Campus. I'm also the vice president for the Behavioral Health Service Line with Avera and medical director for the Avera Behavioral Health Hospital.
And my name is Radigan. Also one of the psychiatrists at Avera Behavioral Health, and my primary role is one of the inpatient physicians.
All right. How long have you been with inpatient with Avera?
Just coming up at 2 years.
Excellent. So, and South Dakota native?
Yep, born and raised, and actually haven't left for any of my training. Went through USD for both undergraduate and through medical school, and then actually stayed in South Dakota to complete my psychiatry residency as well. So.
Well, why leave a good place, right?
I know, right? Had to stay, so.
Excellent. Well, we look forward to answering your questions about PTSD and its causes. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. Each night, we work to answer as many of your questions as possible, given the time we have for the episode. We do sometimes receive more questions than we can cover in the time limit. We do apologize if we do not get to your question, but we encourage you to ask early to give us the best chance to answer. And to encourage your questions earlier, those of you who ask a question during the first 20 minutes of tonight's program will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but be sure to provide your name and contact information when you submit your questions so we can contact the winner. So this is not the happiest of subjects. It's kind of a heavy thing to do, but I think it's really important that we address this. Talking about PTSD, talking about trauma. I know a lot of people are affected by this. How many patients do you see, like an inpatient, that are coming in due to issues with PTSD?
Unfortunately, I can't say that I probably go a day without talking to a patient that has a diagnosis of PTSD. Probably, I would say, depending on the unit, probably about a quarter of patients have PTSD.
Wow, that many. So, and is it something that's kind of seen by itself, or does it have a lot of other psychiatric things that go along with it? Anxiety, depression?
Yeah, honestly, with PTSD, multiple different comorbidities we see, whether that be substance use disorders, depression, anxiety, multiple different diagnoses.
Yeah, and I would say there is as you said, Jill, the diagnosis of post-traumatic stress disorder, and then there's the historical trauma. So, as Dr. Radigan said, we see a lot of PTSD, but among those that we see, say, in our addiction facility, especially among women, it's probably 60 or 70% that have trauma in their background. There are a number of diagnoses in which PTSD is not even listed on their problem sheet. But as we go through their history, they have had trauma at some point, if not through multiple points in their life. And that's one of the sad things is it's not like an episode of trauma makes you immune to future trauma. Unfortunately, many of our patients have gone through this repeatedly. One of the things that I think has opened a lot of people's eyes, obviously PTSD and Vietnam War, and that was kind of a, I guess, enlightenment for a lot of people. But also when we talk about ACEs, the childhood scores that we now look at to see childhood trauma and some of the environments that kids are raised in, and then we see, you know, throughout the lifespan, we see those impact on everything from mental health, but also in things like cardiovascular disease and diabetes and things that we wouldn't necessarily have associated with a history of trauma. But early in life, you know, it sets a course that can be, you know, it has ramifications throughout the entire lifespan.
So it sounds like a lot of patients have this trauma that they've never identified or talked about, and so may not even carry that diagnosis, yet they're still dealing with issues from trauma.
Yeah, and that is one of the things. So PTSD, as you know, has a very specific kind of criteria set in which we would diagnose it. It's a disorder that, as Dr. Radigan said, often is comorbid with other things. But then trauma itself, even if you don't meet the criteria for PTSD, can create things like, you know, chronic interpersonal issues, relationship issues, substance use issues. So we see it as, you know, kind of a foundational part of so many other things that occur in our behavioral health treatment and diagnostic issues.
All right. Do you want to tell our audience kind of what are the criteria for a diagnosis of PTSD? What sort of symptoms are we looking for to say, yep, this is what it is?
Honestly, that's a difficult question because it manifests so differently in every patient that I talk to. And one of the hard parts of even getting the diagnosis into the DSM was trying to develop the criteria, in that it manifests with different thoughts, emotions, behaviors, and so differently in everybody. You know, if you go back to the DSM and just look at that, it has what's called intrusive symptoms. So a lot of these would be problems with reoccurring memories, distressful nightmares, physical and psychological responses to usually some sort of trigger, whether they're able to identify that or not, flashbacks. Most patients are able to identify some avoidance behaviors, and once again can be difficult because sometimes the patients aren't aware of these behaviors. Sometimes family or collateral information is needed to even be able to identify that. The other two big areas for diagnoses are there's negative thoughts and emotions. Some of those could look at like distorted thoughts, feelings of anger, shame, guilt. And then the other big area is arousal and reactivity. So kind of a difficult when you look at it with those words, but a lot of it's like sleep disturbance, being very hypervigilant, easily startled. And those are just some, there's 20 altogether, but those are just some brief examples.
And that startle, that arousal it is a pretty key component, because you think of what creates PTSD in people, and it's kind of that, you know, your body is hyped up, your adrenaline is flowing, you know, it's the fight or flight as we talk about. So that's overstimulated during this period of time when you're distressed, and then that's what reoccurs, and it feeds on itself at times. So the more it reoccurs, the more it keeps, that pathway keeps reinforcing itself. And so that's where you see these folks, you know, we've all heard the story of the person who has a flashback, believes they're in a dangerous situation, can become very aggressive and violent and not even aware. We talk about dissociation, where you're kind of not even in this moment, you're in that moment, the past. And so, as Dr. Radigan said, a lot of times there's not even a complete understanding of what's occurring on the patient side, which is very unusual if you think about it. Mostly we can identify our moods and our emotions. So it does make it more difficult and can make it dangerous, obviously. There are more than a few anecdotal stories and very well documented stories of people being dangerous in the state of a dissociative episode or an intense recollection. But it is, as you said too, it's those re-experiencing of the event in one form or another. You're having a flashback, you have the intense dreams and the physiologic response that comes with that.
And that's all involuntary. They have no control over it.
Right. Can't really turn it off. Can't really, you can turn it on. You talk about triggers and things, and that's where that avoidance starts to become a part of your life. Yes, exactly.
Okay. Well, let's get to some questions here. We're getting lots of good caller questions. A caller from Mobridge is wondering, how do I get referred to a psychiatrist for their PTSD?
Yeah, one of the best ways I would say would be start with your primary care physician. They will usually have a relationship with someone or with a health system that has one. There are, I think you can call soon to be 988-211 is, that's going to go statewide, and they have a lot of information. 988 is going to be a wonderful service, I think, but they're often a connecting point for some people. They're certainly able to help you during crisis as well. But I think for the most part, we rely on the primary care network as one of the best referrals. Every county in the state of South Dakota has a mental health center associated with it, so that may also be a local resource where if they don't have a psychiatrist, they may have a counselor or therapist that could help to direct you to the right level of care.
Excellent. All right. So another viewer's asking, can the docs discuss the NOVA program that was on last night? And about possible treatments of PTSD with medical marijuana or hallucinogens. We were just talking about that with the students before.
Yeah. Do you want to tackle that one?
That's a hard one. I'm going to defer to you.
So it is very interesting. So I think in PTSD, just as a full disclosure, I'm not an incredible fan of medical marijuana in the sense that there aren't a whole lot of studies that necessarily support in behavioral health anyway, the specific application. I would say, though, of those studies, PTSD is probably the most promising in regard to the use of medical marijuana. So I think there is some hope there. And anecdotally, I've talked to veterans and others who would say, it definitely helps them. And that's clearly their opinion. I think what is hard and what's lacking, but will begin to come out more, is that kind of rigorous medical studies that we are in the age of what we would all call evidence-based medicine. So there are things that we have believed have worked for years, but we really all now require evidence to support our decision-making and our choice of therapies and medications. So that will continue to grow. The psychedelics, I think, is another very interesting area, but I think the research is still pretty early. And maybe I'm just cynical or just old, but I've been around long enough to see a lot of things kind of show promise, and then as the research continues, it doesn't pan out. So I don't want to, throw cold water on people's hopes, because there's certainly enough there to make us interested. I do think there is that potential benefit of those drugs that can help you to dissociate or kind of get in a different state of mind, so that you have more clarity with maybe the interventions and the suggestions. So I think there's very clearly hope there, and I understand, I think, some of the basis for how it might work. I think it will be a while until you'll see psychiatrists like myself or Dr. Radigan here, where we're not part of a research institute, probably using those medications. The VA actually does some excellent research, and maybe one of the first places in the area that might have access to that.
Yeah, and we haven't been able to do research because it's, up until this point, has been an illegal substance. You can't do research with a randomized controlled trial with something that's illegal. You would never have an IRB board approve that. You would get in a lot of trouble for yourself, your patients. So, now we might get data, because right now we don't have data. And without data, it's hard to make good medical recommendations.
Absolutely right.
So, yes. Excellent. Well, coping with post-traumatic stress disorder, or PTSD, can be a daunting task. To find out what causes it, how it presents, and what resources are available to help, Prairie Doc reporter Carter Schmidt turns to a clinical psychologist at the VA hospital in Sioux Falls.
Dr. Carrie Lighting says PTSD can be triggered through past experiences such as combat, physical or sexual assault, a natural disaster like a tornado, or a serious accident like a car wreck. She outlined 4 categories of PTSD.
And that first category of symptoms are what we call kind of re-experiencing symptoms, which can include things like nightmares, memories that kind of pop in out of nowhere, as well as memories that may be triggered by something that you see or hear or smell. The second kind of category would be kind of increased negative thoughts and feelings. So things like persistent negative emotions like guilt, shame, or blame. The third kind of category of symptoms are what we call hyperarousal symptoms. So that can include things like difficulty sleeping or concentrating, feeling extra alert or on guard, even when you maybe know you don't have to be. And then the last kind of cluster of symptoms are avoidance, which can look many, many ways, but it could include things like avoiding talking or thinking about the event, as well as like avoiding external things like people, places, situations, smells that remind you of it.
Lighting says PTSD symptoms and treatment options vary from person to person.
Trauma-focused psychotherapies are the most highly recommended type of treatment for PTSD per kind of practice guidelines and research. And so trauma-focused just means that the treatment focuses on the memory of the event or its meaning. And so those treatments can use different techniques to help process the traumatic experience. Some of those can involve visualizing, talking, or thinking about the traumatic event. Others can involve kind of changing unhelpful sort of beliefs about the trauma. Additionally, like medications have been shown to be helpful in treating like PTSD symptoms and can include like antidepressant medications as well as like medications for like specific symptoms such as nightmares.
Lighting says 50 to 60% of Americans have had a traumatic event in their life. Of those people, 1 in 10 men and 2 in 10 women will develop PTSD. Even with support, getting back on your feet can be a challenge.
What do you have available to you, and what do you need to maybe help get you to that next piece of where you would like to kind of get more comfortable with, whether that's using your family and friends, whether that's using an online service, whether that's using VA services here, whatever that is, right, that you might need or what you might need to plug into what you need. Definitely encourage people to kind of make use of those.
Well, that's definitely very good things to hear about the resources at the VA. Actually, a viewer called in and said that they were with the military veteran and wanted to make sure that other veterans knew that the VA has these programs for people struggling with mental health. Said that the closest location they had was St. Cloud, Minnesota, and had a wonderful experience with that program. So that's really good. I know my husband's a military veteran. His brothers and actually sister are. His father was. I know his father had some PTSD issues after coming back from Vietnam, and every year they would learn about Military One Source, which is a website that has a lot of resources for veterans, especially talking about mental health, PTSD, depression, anxiety, suicide risks, all of that, addiction. So lots of help for veterans, but our veterans aren't the only people who suffer from PTSD. It can be any age, any gender, any situation. What's the youngest patient you've had to do with some PTSD?
I mean, it can go back to even very young children. They manifest PTSD a little bit different than adults, may not necessarily have the same nightmares. Adults usually have like the trauma-based nightmares, but children may not. They will just indicate having a scary dream, but it may not be consistent with that trauma. They also do a lot with like reenacting in their play, so you can see some of that trauma come out in their play, but very different. I mean, I think the youngest that I can recall seeing was a 6-year-old on one of the units during our training. Now I typically see adult patients, so not down in the, working with child adolescent now as much, but very young age.
Yeah, so no one's immune to being affected by trauma. So, and is there a point where you can do something so the trauma doesn't turn into PTSD if we get on top of it and start processing those feelings, or?
Yeah, there's been some, I think, some good evidence that early intervention is effective. There's been even some medication trials where try to avoid kind of that, we talked about that cortisol, that kind of axis turn on, that adrenaline turn on. So there are some things if you can get in early, but I think as the VA therapist was talking about, support, immediate support, immediate de-escalation, debriefing, all those things can be effective. So awareness is probably key, and I think we've gotten much better as a country, certainly as a community, after things like tornadoes and others, to really, we unfortunately are in an era of violence, it seems. So after we have events in schools or neighborhoods, we often see a response where we go in and debrief and try to get to those that are struggling. As the data suggests, it's not everyone, so we don't want to imply that everyone who experiences a trauma is going to develop PTSD, but early intervention can reduce the impact, if not totally alleviate it.
Yeah. Do you want to talk a little bit more about what these debriefings are like? I know after we have like a code where someone, they stop breathing, their heart stops in the ER, or we have a bad outcome, a child dies from an accident, that we'll have someone come in and try to debrief the healthcare workers, or my husband's a firefighter. After a fire where someone dies or someone gets hurt, they'll debrief the fire department. Can you talk a little bit about what goes into those debriefing sessions, or when they would be helpful?
So it's kind of like you were indicating, and usually the debriefing, I would say, comes and is probably more appropriate for those large, like natural disasters. And we have so many people with training where that's available. And just as you indicated, kind of walking through it. But it's not even just like the immediate support. I would say it's even the support that comes in the weeks and the months following that are very important. Support even before as well is one of the best prognostic factors. But unfortunately, there's a lot of trauma that is not occurring at a large scale, and that debriefing is not available.
So when there's a group, you can kind of all go into it, because when you're in that situation, your memory of what happened may not be accurate. I know a lot of times with codes, they're like, oh, I couldn't get that IV in, it took too long, that's why the patient died. And the other person was like, no, I watched you got it in 10 seconds. Oh no, I took too long. No, you didn't. And kind of that reassurance to someone else who is there and shared that experience and can share that emotional pain together, I think is really therapeutic.
It's an interesting example, because on so within the hospital we have security cameras, and we'll call a code, and you'll talk to people afterwards as you debrief, and they said it was 5 minutes before this got here, and you can actually literally see the countdown on the clock, and it was under 20 seconds. But it's that distorted time aspect, and that it's that shame and blame and the fear that you're already going through. And so yes, to your point, just kind of emoting what you feel, discussing what happened, and getting a real validated perspective on what actually happened and what your role was. Because I think we all, and particularly I think those that are maybe more susceptible to the trauma experience, they quickly engage in blame and shame, and so they're taking on a lot of negative emotion, and really, we all know that when we're very emotional and our adrenaline is flowing, our judgment is distorted as well. So I think that's where that immediate debrief, or a very rapid debrief. I also do think trauma is somewhat easier to experience with a group and a support than what is. I think that was the point you were making, is there is so much trauma that occurs behind closed doors and to individuals. And sometimes repetitive in nature, and that's the hardest for us to identify, and probably creates, I think, percentage-wise, the most, the longest, worst impact on someone's life is that form of trauma.
Okay. All right. Well, one caller mentioned that he was in a bad accident over 10 years ago where he was hit from behind by a semi. He says now he drives frequently and only sometimes has issues when semis pass him, but sometimes he doesn't. So why is it so inconsistent? Why does it trigger sometimes and not others? Is there a good reason for that? Is PTSD just one of those things that is unpredictable?
Well, I'm going to guess a little bit, having not talked to him, but just the way he describes it, I would my belief is there probably are aspects of when the truck passes him that he's not consciously aware of, but subconsciously are much stronger reminders of the accident than when they pass and they don't. So below kind of his conscious level of understanding it, there is a trigger in the way that semi passed him versus the way another one does. So
The color of the cab.
yeah,
or
the
something
speed
like
they come up, whatever it may be, correct. So there's something in there, and it's just not on the level of conscious awareness, but his body is responding and is very much reminded and triggered.
Okay. So a viewer from Sioux Falls is wondering what programs or education can be implemented in schools or healthcare facilities to help prevent or recognize trauma and provide resources for those. I mean, I think we're trying.
Yeah.
We are. I would say that educators, and so mentioning schools, I think there is much more training, much more awareness of the trauma that's out there, and some of the signs. I think our educators are much better trained in recognizing the signs of trauma that they see in their kids, because it can be, like you mentioned, anger or emotional disruption or difficulty with concentration. Obviously, there's the physical signs, and to give our country credit, we have made the report of abuse to a child or an elder a mandatory thing for school workers, educators, as well as physicians. So we've made a very concerted effort to try to make sure that we intervene more frequently. It can still be subtle and difficult to find. And then I think, there are pathways for those of you that don't know on our viewership. As a mandatory reporter, I don't have to prove it myself. I just have to have a suspicion. I then turn it over to the Department of Welfare and Child Health, and they would investigate that for us.
Yep. And as long as it's reported in good faith, there's no repercussions. So it's always better to report
than not to report.
The system is set up to encourage you to report and let them investigate rather than to hesitate. So, yeah, absolutely.
Not an easy call to make, but one I've made.
And I feel like the schools continue to add more and more resources from nurses to counselors to, I know that there's plenty of psychiatrists in town that even do evaluations in the school. So I feel like throughout the years that continues to develop, and that just like our awareness and being able to make the diagnosis sooner, even within the educational systems, has improved significantly.
Yeah, and I know that it's gotten much better with schools bringing in counselors after there's been a traumatic event. I mean, I remember when I was in high school, I had a classmate that died in a small plane crash over Thanksgiving, and they brought in counselors to talk with us and kind of debrief our class because it was her and her two siblings and father that all perished in this plane crash, and that was really hard. So, it's just concerning when it hits kids at so many different ages. Actually, an emailer talked about a 10-year-old who within last week lost a classmate unexpectedly and had a friend that looks like hit by a car, and is really worried about the mental health effects on that child. So what would you do to help protect or deal with this trauma in an age-appropriate way for a 10-year-old?
I mean, one of the biggest things that I always recommend to families that are like similar experience, saying, I know so-and-so, their child, or they have been through this traumatic or horrific incident, is there is no harm in just starting with a therapist, psychologist, and having the patient see them. They're pretty good at knowing the resources to referral out if they do have concerns, but kind of talking about, there's debriefing immediately, but then even after that, in helping to identify if this has had an impact on them or, an impact on anybody else. So.
Yeah. Definitely.
A good starting point, at least, to start there.
So parents, just be reassuring that you're going to be okay, we're going to take care of you, and get them the resources that they need.
Yeah, and I do think with kids, a lot of it is to have that fairly candid conversation. Hey, it's okay if you're hurting, it's okay. You talk to me about it, and to your point, get some professional help involved so that there's experience there to recognize when there may be a greater problem or a greater issue that needs to be addressed.
Yeah, I mean, it's a lot. We just want to protect our kids and do
Right.
what's right. So I think if you surround them with support and love, and then get them to the professionals who know how to deal with this, that's probably the best thing you can do as a parent.
And to give, I would say importantly too, to give them the tools to manage this. Learning and developing these skills, it does give some resilience that they can then continue to use on throughout life. One of the risk factors for PTSD in and of itself is past trauma. And so if you can learn some of those coping skills at a very young age, I mean, that's only improving if you're going to have any further trauma down the road.
That is huge. All right. Well, Dan Diamond is a doctor who specializes in responding to international disasters. He has been at the heart of devastation many times and shared with us this advice with handling trauma.
My buddy Bob and I both deployed to Haiti during the earthquake. Or just after the earthquake. We were there for the aftershock. It was the scariest moment of my life. We saw stuff that you can't unsee. And we both came home struggling with some PTSD after that one. And again, what doesn't work is to just shove that stuff down and not want to talk about it. That's incredibly helpful. So can I be kind towards myself when I'm suffering and realize that I saw stuff I can't unsee? And that stuff, I would love to tell you that I'm just tough because I'm a disaster doc. And nothing stops me. I'm tough. No, that's not true. Some of this stuff is horrible, especially in Haiti. The injuries that we saw to children were incredibly horrible to witness. So can I show up with myself and say, I'm going to be kind. I want to give you space to feel this. And am I willing to go get help is a really important thing. So I'm a huge believer in going to see some professionals if I'm struggling. Not at all ashamed to tell you that I'm seeing somebody for counseling right now. It's been a tough season. So, I've got a guy I see once a week, and he's helped me navigate through the difficult stuff. I think sometimes healthcare people, especially docs, think, well, I could never admit that I need to go see somebody. Well, no, that's like, am I going to do my own appendectomy? I don't think so. Makes more sense for me to go see somebody else that can see from over there what's going on in here, because I can only see my perspective. I want to show you something. You know what that thing is?
A drive shaft.
Oh, you're so close. No, it's not a drive shaft. Hopefully this will work for you because it's got some sound to it. This is a cable making machine. And it takes all those strands and it weaves them together into one cable, and that cable is strong, but every strand matters. And every person matters too. So PTSD is not a road that anybody should walk alone. Trauma is not a road that anybody should walk alone. What we need are some vital relationships that are built on trust, where we can have meaningful conversations and say, ooh, I'm having a tough time right now. Can I just sit with you?
Next viewer says, can the docs discuss the stigma often associated with PTSD, especially since it's often associated with military veterans, but not often discussed with other situations? So I know we talk a lot about it with vets, with PTSD. That's kind of the first thing that top of mind that comes up, but other things can cause this, like car accidents, rape, abuse, assault. Any of those things can lead to PTSD. And
Right.
yeah.
Yeah, and I would think if there's a stigma associated with veterans with PTSD, it's always about violence, and it's not. I think that we talked a little bit about dissociative episodes and response to triggers, and kind of fight or flight, and you're reliving the experience, so you think you're in a dangerous environment where your life is threatened. But not every vet experiences their post-traumatic stress that way, and we would never imply that veterans with PTSD are dangerous. But I think that if there's a stigma, it's probably that. We just heard Dr. Diamond just describe himself as coming back from a horrific event with some PTSD, and so I think that's the reality. It exists among the entire population to varying degrees, and I would say that although there has been some degree of violence, often poorly directed, not intended, but the vast majority, it doesn't express itself that way.
I mean, I think one of the other stigmas that I hear too is the word weak or weakness, that it's a perception of being weak to seek out help or to have the diagnosis. I think that, with the VA and the increase in resources, that stigma definitely has improved, but that's taken a lot of time.
Yeah, I'd say if I had a concern with the VA is that it's kind of that mentality of the warrior, that exactly what you said. I'm strong, I don't need it, I'm not going to admit a weakness, and yet we know from the suicide rate and some of the other markers of impact of the experiences and the mental health demands of being in the military. Hopefully it is more and more acceptable for those folks to ask for help, and they're neither immune nor is it a sign of weakness.
Definitely. So, caller says, is there any evidence that points to gastrointestinal diseases like irritable bowel or diverticulitis being secondary to PTSD? I know we're learning more about kind of that mind-gut connection. Have you guys read anything about that, or?
Yeah, so I mean, I think Dr. Stanley, you already talked about this, and what I talk to my patients every single day about is whether it be PTSD, depression, or anxiety, that we've had this idea of classifying mental illness here and medical diagnoses here, but honestly they're one and the same, and that when one is off, the other one will be as well. So definitely, I mean, any sort of digestive problem, whether it be ulcerative colitis, any of that, if depression, anxiety, PTSD worse, those symptoms potentially are going to be worse because of stress. I mean, they can exacerbate those symptoms. So I would definitely say that they can worsen each other.
And it is interesting, so serotonin, as we know, is one of the main neurotransmitters that we affect with some of the most common drugs, the Prozacs and Paxils and Lexapros and things. The other area in the body that has a lot of serotonin receptors is the gut.
That makes sense.
So there is definitely some diathesis, some connection between brain and gut, but I think the most important point is, we've had this this artificial dichotomy of brain diseases and body diseases, behavioral issues and health. It's all one and the same. It's one body, it's the same neurochemicals, and they equally affect each other. Poor health will affect your mental health will affect your physical health. They're all one. And yes, I think there's a very clear correlation between some of the irritable bowel and anxiety disorders and things of that nature.
Yeah, so it's not medicine from the neck up and medicine from the neck down.
Right.
It's the whole body, and everything's affected by everything.
Correct, yeah.
All right. Well, a Sioux Falls resident would like you guys to expand a little bit more about historical trauma and its relation to PTSD. It's kind of like concussions where they're cumulative and they kind of add up over time. Or is it just one bad one and it's a problem, or?
Yeah, so I can speak from my own experience. I would say that there are folks, and historical trauma means different things. So I think sometimes we talk about cultural historical trauma as well, and the impact that has, on an entire culture, entire ethnic group. And I think it's very clear that does have an ongoing impact. And if you can have a post-traumatic state within a community, I think that can exist. We don't really categorize things that way, but I think if you look at it with an open mind, you see the impact of that. But let me approach that a little differently. When we talk about like those early childhood experiences and repetitive insults to the brain, to the body through trauma, so that lays down a very deeply ingrained kind of physiologic response to trauma and fear and powerlessness, and that will be very, very hard to treat over the course of your life. I mean, it's not impossible, but we see people that have just chronic ways of interacting with others, and it's very hard to break that, even though it's, you know, their poor coping skills, their poor interactive skills. It's very hard to change how that works. Versus, I think you think of that singular event, traumatic, and this isn't to minimize the impact, but it's easier to work through a singular event, especially a little more recent. I think you have a much better opportunity to be able to emote that, get it out, talk it through, as you said, kind of put it in the proper perspective. You know, the memories from childhood are very difficult to reclassify and put in a safe place and in a safe perspective. So I think it's a very different approach. One is probably has a much better prognosis and shorter course of treatment versus the other.
Okay. Well, a viewer's wondering, have you been seeing more PTSD in people who have been ill with COVID or had post-COVID syndrome? How has COVID affected?
Yes, being on the inpatient side, both patients and then obviously those at front line treating patients with COVID, both because obviously from the patient's viewpoint, now they are in the hospital critically ill. And probably not able to see their family if they're well enough to be able to see their family or talk to their family. No means to do that with the restrictions in regards to visitors. And then those at the front line and working through a pandemic and, you know, having the mortalities to deal with every day and something new to us. Anytime something's new, difficult to navigate. So for sure, I would say on the inpatient side have had more individuals with COVID and PTSD.
Okay, so
I'm sure it's to say you can attest to that probably. Yeah.
It's been a long 2 years.
Well, and I think we still don't fully understand all the ramifications of a COVID infection. So, and we're already starting to talk, or we have been talking about the long haulers, the people that have symptoms that are longer and of greater duration and to some degree different presentation than those that appear to be fully recovering. So I think this story is one that continues to unfold. What we do know though is even if COVID doesn't make you more susceptible to mental illness made you more susceptible to the ravages of COVID. So we are seeing a lot of fallout. You know, I don't know if you noticed that the WHO just put out a scientific brief that said worldwide the increase in depression and anxiety is up 25% post-pandemic, if we're truly post. So that just speaks to the fact that we are in the midst of an ongoing pandemic of behavioral health.
So how do you treat PTSD? We've talked a lot about what it is, who has it, why they get it. How do you do things about it? We talked about some counseling techniques. What do you as psychiatrists do?
So yeah, counseling, EMDR, as we discussed, is a big one. The first, so that even more people know about, is CBT. It's first line indicated for PTSD. On more what we would do, where our roles come in, is medication management. Dr. Stanley mentioned SSRIs are first line, but there are also a variety of other medications that are utilized as well, whether that be, you know, targeting, and when I look at it, it's not necessarily a diagnosis, but really looking at what symptoms, because as I referenced earlier, PTSD is manifested very differently in everybody, and so it's really more looking at like a symptom-based and what medications would be best for that patient.
Yeah, I've always used the analogy, it's like treating the flu a little bit. I can't make the flu go away, but I treat the symptom that is creating the distress.
Yeah, so excellent. Well, there's a lot that we were able to unpack here tonight. This was a lot of things to talk about, and a lot, not the happiest of subjects, but I think a very important one that we kind of destigmatize, that we make it okay to talk about, and people to ask for help and make sure that they talk with their doctors, talk with their mental health providers, talk with their family members, and try to support, as best we can to get people through these very difficult situations. So. All right, well, our winner from our drawing tonight is Valerie from Madison, South Dakota. Thank you, Valerie, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
We live in a busy, noisy, and pressure-laden world. Being able to deal with that environment is not easy. Coping with stress, anxiety, and depression tonight. On Call with the Prairie Doc. Life is often very difficult. Every individual will confront stressors in different ways, and sometimes we just need help. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Post-traumatic stress disorder, or PTSD, was first listed as a medical diagnosis in 1980. However, it has been recognized and called by many different names throughout history. The first recorded description of PTSD is in the Epic of Gilgamesh, which dates back to 2100 BC. And in the Iliad and the Odyssey, Homer wrote about the Trojan War soldiers exhibiting the symptoms of PTSD. Shakespeare described a character in King Henry IV who suffered from post-traumatic nightmares. During the Civil War, the terms irritable heart and soldier's heart were used to describe PTSD symptoms. In World War I, it was called combat stress or shell shock. In World War II, it became battle fatigue and combat exhaustion. PTSD is not limited to soldiers, as the term concentration camp survivor, survivor syndrome, battered child syndrome, and rape trauma syndrome were all recognized as conditions in the aftermath of World War II. PTSD is a mental health condition resulting from experiencing trauma firsthand or from witnessing others undergoing a severely traumatic event. It can also be a result from repeated exposure to distressing details of an event. For example, many firefighters and other rescue personnel who search for survivors after the 9/11 attacks suffered from PTSD. The traumatic experience can lead to flashbacks or nightmares, which can progress to physical reactions such as rapid heart rate or shaking when reminded of an event. Individuals with PTSD will often avoid any person, place, or activity or object that could trigger memories of the event. As a result, they may feel detached from others or have persistent negative thoughts about themselves or others. They may have difficulty experiencing positive emotions like joy or happiness. Another common symptom of PTSD is hypervigilance and always feeling on guard. This in turn can cause problems such as excessive sleeping, irritability, aggressive behaviors, heightened startle response, or difficulty concentrating. If these symptoms last more than 1 month and interfere with multiple areas of a person's life, then they meet the criteria for the diagnosis of PTSD. PTSD is best treated by psychiatrists and psychotherapists with special training in this area. Treatment often involves a combination of medication and therapy. Support groups, exercise, and mindfulness practices are also healthy coping strategies. And, as with any sickness, compassion from family and friends is crucial. While the name for this illness may have changed, PTSD has been acknowledged for centuries. If you or someone you know is suffering from PTSD, don't wait. Talk to your doctor, counselor, or spiritual leader. For more information, call the Substance Abuse and Mental Health Services Administration National Helpline at 1-800-662-HELP, 4357, or text HELP for you, 435748. Well, thank you to our guests, Matt and Veronica, for volunteering their time to help us learn more about the topic of PTSD and past traumas. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. So from all of us here at On Call with the Prairie Doc, as we celebrate our 20th season of truthful, tested, and timely medical information, until next time, stay healthy out there, people.
To say something is skin deep implies a shallowness that fails to recognize the depth of the function and protection that our skin provides. Dermatology 101, next time On Call with the Prairie Doc, celebrating our 20th season.
Prairie Doc programs have provided truthful, tested, and timely medical information for 20 seasons. Hello, I'm Dr. Jennifer May of Rapid City, and I serve as a board member for the Healing Words Foundation. Please join us as we celebrate this milestone, offering healthcare information in our state and across the region. Rick and Joni Holm began this mission years ago, and every week since then, our Prairie Docs and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free and easy access to the entire Prairie Doc library. I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swift Telecommunications.